Welcome to the Physicians Lounge, a podcast of the Mississippi State Medical Association. The Physicians Lounge was created to provide ease of access to information and resources on current topics affecting healthcare. This episode provides an overview of the health priorities in the state of Mississippi and the programs being offered to address them. Joining us today are Dr. Paul Byers and Dr. Daniel Edney. Dr. Byers is the former state epidemiologist with the Mississippi State Department of Health. Dr. Edney is the state health officer for the Mississippi State Department of Health. The Mississippi State Medical Association is accredited by the Accreditation Council for Continuing Medical Education, ACCME, to provide continuing medical education for physicians. MSMA designates this enduring activity for a maximum of 0.5 AMA PRA Category 1 credits. Physicians should claim only the credit commensurate with the extent of their participation in this live activity. To claim the CME credit, please go to the MSMA link in the show notes to register for the CME and receive the required evaluation. If you have any questions, please contact Jenny White at jwhite@msmaonline.com. That's JWHITE@msmaonline.com. In compliance with the ACCME and MSMA standards for commercial support, today's speakers have asked me to advise you that they have no relevant financial relationships to disclose. Planners of this activity were also asked to disclose relevant financial relationships concerned with the content of this activity, and they have nothing to disclose. Thank you for joining us.
Hello. Welcome to the Physicians Lounge. I'm Dr. Paul Byers, former state epidemiologist at the Mississippi State Department of Health, and today we are joined by my friend, Dr. Dan Edney, who is the State Health Officer of Mississippi. And, many of you should know Dr. Edney. He's probably familiar. He's had more than 30 years of experience in private practice, internal medicine, addiction medicine. He was a former president of State Medical several years ago. Dr. Edney, welcome.
Thank you, Dr. Byers. It is a pleasure to be here and great to see you again.
Oh, well, thank you.
We absolutely miss you at the Health Department.
I appreciate that, and I certainly miss y'all as well. So you've been on the job now for a bit over a year.
Is that all?
I know it's longer. And there are several challenging health indicators in Mississippi that can be considered some of the worst in the United States, and I know that we can certainly list them. I know that infant mortality is certainly one of the issues that we face. Obesity, high levels of hypertension,
right,
stroke, diabetes, other chronic diseases. We've been seeing some increases in drug-related deaths and impact from that, and certainly access to care is always an issue as
It
well.
is.
And with us thinking about that as we've come out of the pandemic and the stress that that's put on the health department and the healthcare community, and certainly we're seeing some increases in COVID now, but that's not unexpected. From your perspective of a little bit more than a year on the job, what are some of the public health priorities in the state that you're focusing on?
Well, it's really clear to me, and if you're listening to the conversation, just out in the community and with other partners in this space, maternal infant mortality is number one priority, and we set that priority coming out of pandemic response as we were unwinding the response, which you were a big part of. It was clear that public health had suffered in our state and really across the nation, first because of poor funding before the pandemic, and then the pandemic hitting, it meant virtually shutting down access to community public health for 18 months while everybody was responding to the urgent needs of the pandemic. And now coming out of that time period, we're seeing surges of syphilis spilling over into our pregnant women, generating way too much congenital syphilis. Where the maternal infant mortality rate is going the wrong direction, and these are not Mississippi specific. These really are across the nation, but they're just intensified for us because of the amount of poverty that we experience, and relatively poor investment at the state level into public health. So, number one, maternal infant mortality. Number two, diabetes, which plagues our entire population and generates so much, bad outcomes in terms of cardiovascular risk, amputation rates, hemodialysis rates, blindness, you name it, and it ties directly to obesity. It's interesting, we moved from first to fifth in obesity.
Yes.
And we haven't done one thing better. But I guess everybody else did worse.
It's all relative.
It's all relative. And then thirdly, we have been really focused on the opioid crisis. And I'm proud to say, because of the aggressive naloxone distribution program between us, Department of Mental Health and Department of Public Safety, that we have reduced the number of deaths, although we haven't reduced the number of overdoses yet. But like I say, you can't treat a dead patient, so keep them alive and try to get them access to treatment. So those are our top three priorities. You know well that at the health department, every day is a new challenge. And I've learned that lesson very quickly.
There's always something new on the horizon that you haven't even thought of yet.
I was on the job 2 weeks when Jackson water crisis hit.
Yes.
So when you look at the jurisdiction of the Mississippi State Department of Health and all the things that we're responsible for in terms of, regulating or service provision, it's a heavy lift. And with that broad jurisdiction, something's always going to be, popping up for us to have to deal with.
It certainly stresses the resources.
It does.
So I know that you're working on developing and putting a team in place at the Department of Health now. You mentioned naloxone distribution as one of the ways to combat increasing drug deaths. What are some of the other things that you're doing from the Department of Health? I know that there's healthy moms,
Yes.
healthy babies. Tell us a little bit about that.
Yeah. So, staying with our number one priority of reducing maternal infant death, and along with that, morbidity, because a lot of the women who survive pregnancy are quite ill as a result of the complications of their pregnancy. We have spent a lot of time and resources rebuilding our Maternal Infant Bureau, developing a more robust women's services department, and under that comes really all of our high-profile work for maternal infant death reduction. So the Healthy Moms, Healthy Babies program is a nurse case management program in the home. So it's a home visitation model funded through our partnership with the Division of Medicaid. And one thing that we have seen nationwide, the evidence is clear that home visitation models work and they reduce mortality. We're working with the nurse model because we know we have to not only case manage, but we have to intervene. And there's a lot of case management going on. But if you can't intervene when one of our pregnant Medicaid moms has an urgency related to social determinants of health, you're going to have a bad outcome. So having the nurse in the home, having that multidisciplinary team around him or her, and being able to literally hold that mom's hand through her pregnancy so she survives it. I hate that we have to talk that way, but that's what we're talking about, is helping our Medicaid moms not die in pregnancy. And I'm convinced as that program becomes more robust that that will help us move the needle.
And so how long has that been in place?
I would say, nurses in the field a little over a year, and it's steadily growing. It's a huge investment in the nursing workforce, and which is a challenge in public health as it is. And this is putting more stress on the workforce, but it's just something that we have to do. The other really major project that we have kicked off, many of our listeners will know that one thing in Mississippi we do well are systems of care, and we really lead the nation in that work. originally with our trauma system of care, followed by STEMI, stroke. Y'all did amazing work with the COVID system of care and saved a lot of lives by moving people where they needed to go and not, getting the system out of the way and making it happen. The evidence shows clearly that in addition to home visitation models, that understanding what birthing hospitals can do and really what they're not qualified to do based on staffing and resources makes a difference. It's very important that high-risk pregnant women deliver at the right place at the right time. And it's the same way if you have a heart attack, we're not going to the small critical access hospital. We're moving you to the closest cath lab. Mm-hmm. And if trauma with head trauma, you're going to who can handle head trauma. And right now we have women that themselves are high risk, or they have a high risk fetus that, once delivery happens, it's going to be a very high risk infant, neonate. If they deliver at the wrong place, the odds are against them. And we know in the Mississippi Delta there are no NICUs. So for high risk pregnancies that are going to have a high risk neonate, that mom needs to deliver at the right place so that baby has immediate resources and not waste time transferring. Taking the concept of maternal levels of care, which is where we survey birthing hospitals and we determine what level they are, and they're designated maternal level, 1 at the highest, 2, 3, 4 at the lowest, same way we do with all of our systems of care. And you receive your designation and you can go up if you want to by investing more, adopting more of the AIM safety bundles, having more shorter response time with your OBs, just all the things that really ACOG and Joint Commission already have in place. But moving from a voluntary attestation model from hospitals that we have now to a mandatory survey-based model where we know who can do what. And then and the one thing that there are 10 other states already doing that. But the thing we're going to do that no one is doing is tack on the comprehensive component of the system of care. And that means, training EMS to be able to recognize and start treatment at the home or at the roadside, and continue treatment and transport just like we do with trauma and STEMI and stroke as that pregnant mom moves to the right place to deliver at the right place at the right time. No one is doing that. So to me, it just makes perfect sense. We know the evidence is clear on maternal levels of care. We have proven systems of care over and over and over, improving outcomes. And so we're excited to be partnering with the Mississippi Healthcare Alliance to develop this obstetrical system of care and beginning in the Mississippi Delta. A regional approach is a smart way to go. So the Delta has the highest need, has the highest rate of maternal infant death, and has the lowest resources. So despite it being the largest challenge to implement a system, it makes sense. That's where we need to start.
And has there been positive buy-in from providers, from delivering hospitals?
Thus far, the rural the rural physicians are begging for help. They're just overworked, stretched tremendously, and and they frequently encounter resistance when they're trying to transfer a high-risk mom. And time is everything. And so that time wasted and trying to get an acceptance and transportation arrangements made, the system of care, as takes care of it. And if these are moms that a hospital's capable of handling, that's where she needs to deliver. If they have the resources for the baby, that's where she needs to deliver. But I know we have a lot of frustration among OBs in the Delta because they don't have what they need. They're experts.
Mhm.
They're fully qualified as obstetrical specialists to handle it. But we all know as physicians, if you don't have the resources, to apply the treatment plan that you know is appropriate, it's not any good.
You need that supportive infrastructure.
We do, and so unfortunately in the Delta we have hospitals, we have birthing hospitals with no intensive care unit, much less a NICU, and you have a high-risk mom. Number one is cardiovascular cause of death. How do you manage cardiovascular crisis without intensive care unit?
Yeah.
So I mean these are just practical steps we need to put in place. It'll take a little time. We're going to be thoughtful in our development, but as I'm telling everybody, we're out of time.
So how far down the road before this can be implemented, even in the Delta?
We're, the Mississippi Healthcare Alliance are really the experts at helping us develop systems of care. So they're excited. They see the same potential that we do. So we're at the very first steps of organizing a system. And part of that is partner buy-in and, getting the word out. And all of this is within the authority under the Board of Health, to do. So we don't need special legislation.
Right.
I do need funding, but I'm not going to let that stop us. This is work we have to do. And Paul, I'm convinced the combination of the Healthy Moms, Healthy Babies program and the obstetrical system of care in the Mississippi Delta will save lives and move the needle. And from a population standpoint, when you make small progress in the Delta, you make big progress statewide.
Yes.
And so it's one of the advantages of when you're doing so poorly, a little bit of improvement makes you look really good.
So how long down the road are you thinking you might start to see some improvement from the Healthy Moms, Healthy Babies, home visits, intensive work there?
Yeah.
Or are you seeing it already?
It's still too early, and the numbers are too small. We're taking care of about 700. So when you're at a population level, that it's hard to, to see much needle movement yet. But and I'm also, really Healthy Moms is almost doing it one at a time.
Yeah.
But I think it's what we have to do for those really high risk moms is just help them individually to get through. Even though we're 50th in the country and every news outlet in the nation wants to call and ask what's going on, the numbers are still not huge numbers. They're just numbers that are too high.
Right.
And they're they're out of line with the rest of the country. But it's not like we have to rescue 200 moms. It's more like 5
to make a difference.
To make a difference. And I'm determined that we're following the evidence. We're going to be data driven. We don't have extra resources to speculate. We have to invest our limited resources where we know we'll get a return. And I believe that 2-3 years down the road, this needle's going to be moving, and by 5 years, not only will we be out of the ditch, we won't even be on the radar anymore. We'll, in terms of maternal infant, we're going to push hard so that we're not showing up in the top 10.
And that would be huge.
It would be. And I've told, when I talk to the New York Times or Time Magazine, I'm open and transparent,
Mm-hmm.
and I tell them what we're doing. And then I say, and I'm expecting you to request an interview in 3 years when you see, wow, what's happened.
And I know they will.
Oh, they will.
So how can providers connect their patients to this program?
Yeah, great question. They can call their local health department, who will have the information. There's also, I don't have it with me, but it's on our website. There's a central number that you can call in referrals, and the Central Healthy Moms office will take it and run with it, or your local county health department will help.
So check the website.
Yes.
For sure for additional numbers and
Yeah,
information.
just search Healthy Moms and it'll pop right up.
And you had mentioned funding, and I know a lot already come back to funding, and I know that you've demonstrated a strong relationship with the legislature over the years, and certainly since you've been health officer. And you had mentioned you just come back from the Capitol just a little while ago. So, how does both federal and state funding play a role in what the Department of Health does? You had mentioned at the health department we have lots of responsibilities, and I still use the we.
Yep.
And I think much of what we do at the health department, even healthcare providers in the state don't realize the responsibilities that the Department of Health has and the role they have to play with very stretched and often thin resources. And so where does that funding come from, and how is it impacting what we can do?
Yeah, we are rich in federal funding, as you know, and when you look at our total budget, 80% of our funding comes from federal programs and our federal partners, and then 15% right now, 15%, but we're going to grow this. 15% of the funding comes from what we do in terms of our fees and our clinical service revenue. Because when we see patients in the health department that have Medicaid, we bill Medicaid. So we generate revenue in our clinical operations that stays within our work. And then a grand total of 5% is state appropriation. That is, if it's not the lowest, it is one of the lowest. It's definitely the lowest in the Southeast. And just, a relative comparison right now, we're our state appropriation, and I'm talking about our core appropriation, that the money that's given to us as an agency to do good work
for health department activities,
right? Versus the pass-throughs. They give us the money to give somebody else, and about half our appropriation is core public health. The other half is pass-throughs, and that equates to about $1,650 at this point per person per year in Mississippi of state investment into public health, versus Tennessee, that's over $70 per person per year.
Staggering.
And the closest above us is Kentucky, and they're at $27 per person per year. So, getting close to double. So we go from us, and the next lowest southeastern state is double what our investment is. And then we wonder why our outcomes look the way they do. We wonder why we have a surge of syphilis when, you remember the days when we had syphilis under control, and we're looking at eradicating the thing. And now it's out of control. And congenital syphilis doing what it's doing is absolutely preventable. This is because we're not investing in core public health, not giving us the resources we need to do what you did for how long?
30-something years.
I mean, what it takes to control a syphilis outbreak, but you can't do it, with 50% of the workforce you need.
So we can't do these things alone.
We cannot.
And certainly we need help from our listeners. We need help from primary care providers. What can they do? I mean, you mentioned syphilis and certainly congenital syphilis. I think one of the easy things, if you see someone who has syphilis, make sure they get treated. If you need assistance with treating, contact the Department of Health, and certainly report that.
That's right.
To the Department of Health, so the department can do an investigation, can identify those contacts, can get those contacts in and get them treated. And it's even more important with pregnant women. And now we do require treatment, pregnant women, for syphilis,
right,
and testing for pregnant women for syphilis. And those are some big movements we made just recently. But what can providers do with this?
Yeah, that's a great question. Practicing in Vicksburg for over 30 years, before the pandemic, man, I knew you and Thomas and Mary, and looked up to Ed Thompson when I was just a punk young doctor, and boy, appreciated what y'all did. Thank God that you were there. Didn't even know where the health department was, and certainly didn't know what was going on in the health department. I just knew if I found certain things, I needed to call the health department.
Right.
And the health department would take care of it. Through the pandemic, that relationship got much tighter, which is one way we got through the darn thing. And as a private clinician through the pandemic, utterly depending on the expertise of public health to teach us what this bug was, how to fight it, what we needed to do, how to educate our patients, and then public health needed private clinicians to get the job done, to take care of the patients. And after the mass vaccination effort was over, then just one at a time, trying to get community immunity up. And that partnership was glorious and priceless.
Yes.
And I'm determined that coming out of the pandemic, that continue, and that clinicians today understand the value of the relationship, and that they are part of public health. And actually, every licensed physician in the state of Mississippi has public health obligations as part of their medical license. And that's simply report the reportable illnesses, and comply with appropriate public health orders and instructions, which our partners are great with. But even going further, understanding you're the front line, and when you see things, call us.
And that's what I always said. Providers out there, when I would talk with them, they're our eyes.
They are.
The health department cannot know what's going on without the providers.
And I look at it as, our state epidemiologist and all the resources that we bring to bear for y'all to do your good work. Y'all are the soldiers, the warriors on the tower. You're guarding the wall. You're out there looking and being vigilant for what's coming. And then, the private clinicians are out there doing the work. And I one thing when I present what we do with the health department, I said in our epidemiology work, this is so important because, these crazy bugs that you don't know how to pronounce, you don't need to, because Paul Byers knows how to pronounce it. Paul Byers sees it, recognizes it, determines if it's an organism of concern or not, and if it's becoming a concern, like Candida auris became of concern, then we alert our partners in the community, and not just alert them, but then bring expertise and provide the resources we can to help, understanding that they have the heavy lift of taking care of the patient.
And so glad that we were able to have such a strong replacement for Paul Byers in Katie Taylor.
Absolutely. She's doing a great job.
Fantastic.
She really is. But for our private clinician partners, just to understand how much we value the relationship, and we are always happy to take up the slack in the areas where we can, such as administering Bicillin that may be too expensive for you to stock in your private clinic. Let's just make sure we don't miss the handoff.
That communication.
If you hand them off to us, we're glad to assume the burden of paying for treatment and watching the follow-up, and then getting to work on the investigation, to try to contain. But we have to do that together. So the worst thing to do is, to find a case and treat it and move on, and it not get reported and we don't know about it, and that whatever's going on in the community is still going on, and not allow us to have opportunity to intervene. And then what you're alluding to is to be advocates for public health.
Yes.
I think, most doctors get it. The reason we're not living in fear of tuberculosis is because of what we do with the health department. And we still vigorously fight TB, don't we?
We do.
And if we stop, you and I know what will happen. It will.
We've seen it happen before.
It's just going to bloom right back. So it's a constant, vigilant battle that we in public health, working with our private partners, do. It's always been a wonderful thing. I didn't have to stay on top of the latest TB treatment because I had the health department. Mm-hmm. Whenever I had suspected cases, we immediately reported it. Health department steps in and provides enormous expertise, because there are plenty of areas in the state that don't have infectious disease support, but they have the health department.
But it takes resources. It takes funds.
It does. So, and we're so grateful for state medical being a powerful advocate for public health in the administration as well as at the Capitol, advocating, for proper funding of public health, supporting our good work. And I want it to be abundantly clear that, the relationship remains strong and we're in lockstep. Public health and private medicine have to move forward arm in arm for the sake of the population of Mississippi.
Well, it's been so great to sit and visit with you and see you again. Any other words of encouragement or concern that you would like to let the listeners know?
I do want to say I'm very jealous of you. We're pretty close to the same age.
I think we are.
I'm truly grateful to have this opportunity. As you well know, this was nothing I envisioned or sought or expected, but it's just one of those turns of life where a challenge is given, and I'm grateful to have the opportunity. I'm grateful to have the team that was in place. I'm grateful to you for sticking out another year and not leaving me last year high and dry.
My pleasure.
And it was extremely helpful having, and I know you and Jim Craig, our previous senior deputy, so many hung in there a little bit longer so the new guy would have a chance for the sake of public health. And I appreciate that very much and look forward to this next phase of relationship as you continue working in public health and helping us get off the bottom. We're going to do it. We have to do it. We did it in education because we started investing in education.
That was the key.
That was the key. So when we, not if, but when we, especially as the medical community, push hard enough, long enough, for our decision makers to invest in public health for the sake of the population, not for the sake of a state agency, but so we can make things better in the Mississippi Delta and Southwest Mississippi and, everybody who depends on us for all the things we do. We've got to be there for them. And we can do this. We are going to get off the bottom.
Let's do it together.
Amen.
All right. Thank you so much.
Thank you, brother.
Thank you for joining us. Show notes for this and MSMA's other episodes are on podbean.com or on msmaonline.com. Support our show by subscribing, leaving a review. Thanks for listening and see you next time. Brought to you by MSMA. We are the physicians who care for Mississippi.